Good morning, Peter Goertz. I'm a psychiatrist. I struggle with this issue, and that is what to do about people who may be malingering, for example, in the emergency room, and what to do with them as a psychiatrist. So recently I had a patient who presented to the emergency room complaining of suicidal ideation. And when I spoke with him more, I realized that the suicidal ideation depended on whether he had a place to stay or not. So he freely told me, "Doc, if I had a place to stay, I wouldn't be suicidal." So if he had a good place to stay, so that's the issue. That's part of the issue, is that he did not have a place to stay that he found acceptable. The place he'd been staying in had been very difficult for him. So in this situation, we're talking about conditional suicidal ideation. So he was suicidal as long as he had no place to stay or not a good place to stay. And that's something that has various aspects to look at. We have, in the medical system, in any country, we have very limited resources. And to admit someone to a hospital ward is something that costs a lot of money. To have a person stay in the emergency room for an extended period costs a whole lot of money. And even for them to present to an emergency room one time costs a lot of money. So if someone presents with conditional suicidal ideation, so feeling suicidal because they have not a good place to stay, they don't have money, for example, what can we do? And if we do have that patient enter into our treatment system, for example, if we do admit that patient to a hospital ward, what is our goal? How can we help the patient? And before that, the question would be, can we help the patient? And on the other side of the coin, if we do not admit the patient, what's going to happen? Are they going to go down the road to the next emergency room? Are they going to come back in a day? So these are very difficult issues, and there are different layers and aspects to this whole topic. So a few examples for things to think about. When I was a resident, another resident saw a patient in the emergency room who really wanted to be admitted to the hospital, a psychiatric patient, and the resident did not feel that the patient warranted admission to the psychiatric hospital. So the patient on the hospital grounds left the emergency room and on the hospital grounds tried to hang himself. But what he tried to hang himself from broke, and he survived. So he could have died. On the other hand, the fact that he tried to hang himself on hospital grounds may tell us that the suicide attempt, at least in part, might have been related to anger at the resident who did not admit him, may have been related to spite in part. So how do we deal with a situation like that? What would have been the best way to proceed with that patient? Another patient, another example, a patient may have malingered, or at least in part malingered, and was admitted to a psychiatric ward. Now, unfortunately, during that hospitalization on the psychiatric ward, he got into a fight, had his jaw broken, it had to be wired. He was urinated on while he was sleeping by another patient, and then when he tried to get up, he slipped in the patient's urine and fell down. So if someone is admitted to a psychiatric hospital, bad things can happen. So in this case, this patient may have malingered to get into the psychiatric hospital, and he had difficulties that he encountered. And in fact, it seemed so bizarre that the medical student who was describing this to me, it was a patient that was followed by a medical student, the medical student couldn't stop himself from laughing because it just seemed so bizarre, the whole situation, being urinated on, falling, etc. So another example, a patient whom I saw as a resident, and this patient, the interview went well, he was calm, cooperative, until I mentioned the word shelter, because I did not feel that this patient needed to be admitted to a psychiatric hospital. As soon as I mentioned that word, the patient got up, overdosed on his whole bottle of medication, ended up being admitted to the ICU. So what would have been the best way to proceed with that type of patient? Difficult issues, because on the one hand, he in part may have been trying to manipulate, and people could say if he were truly, quote, truly suicidal, he would not have overdosed right in front of me. On the other hand, he could have died potentially, depending on which medication he would have overdosed on. So malingering, quote, malingering. Let's look at that. If a patient, quote, malingers to get into a psychiatric hospital, that's in itself something to look at, in my opinion, because he's going to be locked up on a psychiatric ward. He may be with psychotic people, patients, unpredictable patients, potentially violent patients. So for someone to want to be on a ward where things potentially can be dangerous, and at the least where he's locked, he doesn't have his civil liberties, that may, in my opinion, indicate that just by that fact that the patient wants to or is trying to manipulate, potentially manipulate to be on a psychiatric ward, that may, in my opinion, indicate in itself that the patient has some underlying psychiatric issue. But a question, of course, always is that issue treatable in an acute psychiatric setting? Is it something we should put resources or expend resources on? But it does show if someone is so desperate that they want to be admitted to a psychiatric ward, it does show that they are seeking help on some level, and we may want to consider trying to help that person. So what we're doing in these situations is trying our best to balance the limited resources, very limited resources, with what would happen if we do not admit that patient into our psychiatric system. So if we want to use our resources to try and help a patient, do they have an acute psychiatric illness or an acute psychiatric problem that we can even help with? Is it something, in other words, that's treatable on a psychiatric ward, for instance? And then we have to still, in my opinion, consider if we do not think that patient has a psychiatric illness, an acute issue that's treatable on a psychiatric ward, then we still have to consider the possibility that that patient may kill himself or herself, even if they don't have what we would call a treatable acute psychiatric illness, like that example I gave of the patient who tried to hang himself, or the other example of the patient who overdosed on the whole bottle of medication in the emergency room. So bottom line, people can die even if we don't think they have a treatable acute psychiatric problem. So we do, in my opinion, still want to consider doing our best to help people who present to the emergency room, even if there is an element of malingering or possible malingering, possible manipulation, because underlying that manipulation, underlying that potential malingering, there often is a desperate person looking for help. Now, again, we have very limited resources. So I understand when people say we don't necessarily want to expend resources on a person who does not have an obviously treatable acute psychiatric illness. On the other hand, in my opinion, we do want to try our best to help them because we know that they may still kill themselves or they may still come to harm even if they don't have something that we would see as an acutely, at least not easily treatable psychiatric illness or psychiatric problem. Thank you very much.